Hello, ladies and gents, and welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Yomna and Nour, your host for today's episode, and I'm joined by our amazing co host and one of my dear friends, Nour Al Farra, to talk about the tiny but mighty butterfly shaped gland in our necks called the thyroid gland.
Hey, thank you for having me and for that wonderful introduction, Yum. The thyroid really is mighty, and it functions as the body's own speedometer, controlling how fast or how slow everything runs. And as you said, it's mostly known by its butterfly shape, and it sits right in the middle of the neck.
This fluttering butterfly functions with a pretty interesting negative feedback loop. The hypothalamus releases thyrotropin releasing hormone, also known as TRH, which stimulates the pituitary to release thyroid stimulating hormone. And this tells the thyroid itself to produce T3 and T4, which are the thyroid hormones. And once there is enough T4, the system will shut itself down, which is a classic example of feedback inhibition.
Don't forget that the thyroid also produces calcitonin from its parafollicular cells, which helps regulate calcium levels, especially during bone formation and resorption.
And just like your classic speedometer, it can go real fast, real slow, jam, malfunction, etc. And this is precisely what we will be discussing today. We'll start with hyperthyroidism, including Graves' disease and the classic goiter. Then we'll move to hypothyroidism, with a special look at cretinism. After that, we'll talk about the different types of thyroiditis. And finally, we'll wrap it up with some thyroid tumors, both benign and malignant.
I hope you and our listeners are ready. Having a coffee and a little sweet treat is optional but recommended while you listen. We have a lot to cover today, so let's jump right in with the case. A 32-year-old woman presents with an unintentional weight loss despite having a crazy appetite. She specifically used the classic saying to describe her appetite, saying she can easily eat al-akhbar wal-yabis, or everything from the green to the dry. She also says she's feeling constantly overheated. She tosses and turns in bed instead of sleeping, and her heart races all the time.
It sounds like everything is in overdrive. And does this lady happen to be warm with damp skin, a tremor, and perhaps with a wide, unblinking gaze?
It sounds like you already have a differential in mind. Or you read my mind. Yes, she did present that way exactly. So give me your differential.
Is this hyperthyroidism?
Bingo! This is a classic presentation of hyperthyroidism. Everything is in overdrive. In this case, the thyroid gland is producing too much T3 and T4. But here's the distinction. Hyperthyroidism refers to hormone overproduction by the thyroid itself, while thyrotoxicosis is a broader term that describes any condition with excess thyroid hormone in the body, regardless of the source.
Okay, so hyperthyroidism is only one cause of thyrotoxicosis, but it isn't the only one?
Exactly. Thyrotoxicosis can result from overproduction, thyroid gland destruction, or even taking too much synthetic hormone. The most common cause is Graves' disease, an autoimmune disorder where antibodies stimulate the TSH receptor, essentially tricking the thyroid into working overtime.
So it's an autoimmune condition. So I'm going to go out on a limb here when I say that most cases are seen in women. Am I right?
You definitely are. It mostly affects women in their 20s to 40s.
So while Graves is the most common, I also want to mention that there are also other causes for this thyrotoxic state. When we're discussing glands, we usually see quite a few cases of a nodule of sorts that independently secretes a hormone. In the case of the thyroid, some examples would be the toxic multinodular goiters and adenomas. Interestingly, if a person already has underlying autonomous thyroid tissue and is suddenly exposed to a large iodine load, like when we give contrast and imaging, they can go into this thyrotoxic state. We call this the Jode-Basedow phenomenon. Apologies for the little tangent there. Back to Graves. Tell me, Nour, what actually causes all those symptoms?
I actually didn't know about this phenomenon. Anyways, Graves is all about autoimmunity. The body produces thyroid-stimulating immunoglobulins, TSIs, that bind to the TSH receptor and mimic TSH. That leads to overproduction of thyroid hormone.
So would this also lead to growth of the thyroid gland itself, giving us the characteristic goiter?
It sure does. The goiter is such a classic sign. Though, we should also note that the other classic sign is not directly caused by the growth of the gland. The bulging eyes seen are caused by those same antibodies that will stimulate fibroblasts in the retroorbital area. This leads to inflammation, edema, and deposition of glycosaminoglycans, which causes exophthalmos, also known as the classic bulging eyes. Interestingly, exophthalmos is not seen in other types of hyperthyroidism. Graves is the only one with the classic triad of hyperthyroidism and exophthalmos.
Hold on. You said triad, but those are two things. Are you sure you didn't mean dyad?
The third limb of the triad is pretibial myxedema, which is caused by the same fibroblast stimulation seen in the exophthalmos. This is just localized thickening of their skin over the shins. There, now it's a triad.
Apologies, Noor. Counting was never my personal strong suit. Anyways, if we suspect a case based on the characteristic physical signs, what else should we look out for to strengthen our diagnosis?
Remember when we said the speedometer is in overdrive? Well, think of anything that could reflect that in the body. We would see weight loss and increased appetite. The metabolism is being extra speedy. Think heat intolerance, sweating, and warm skin. You'd also see a tremor and a palpitating heart. Finally, you'll also see hyperreflexia, or an increased reflex response.
So, weight loss, increased appetite, heat intolerance. Okay. How about you give me some lab values?
TSH will be low due to negative feedback. Free T4 and sometimes T3 are elevated. You can also check TR antibodies or TSI antibodies to confirm Graves. And imaging-wise, a radioactive iodine uptake scan will show diffuse increased uptake in Graves.
Alright, so we've now covered how to hunt this condition down, so how do we tackle it exactly?
The fight against Graves is made of 3 battalions. First, we have the anti-thyroid drugs, which reduce the production of thyroid hormones by inhibiting the enzyme thyroid peroxidase. The first line is methimazole, unless the patient is pregnant. Then we would prefer to use propylthiouracil, because it has a lower risk of causing birth defects. Our next battalion is the beta blockers. These are just for symptomatic control. Finally, we have radioactive iodine ablation, which we'll refer to as RAI throughout the episode, which uses radioactive iodine 131 to selectively destroy overactive thyroid tissue. Usually, this brigade is called when relapse occurs or when the antithyroid drugs are just not enough.
And surgery is also an option, particularly to remove the goiter. So tell me, Noor, what about thyroid storm? Sounds kind of spooky.
Ah, yes. This is a life-threatening complication where everything is amped up to 100. You'll see fever, confusion, arrhythmias, and it needs aggressive management with beta blockers, antithyroid meds, steroids, and supportive care.
You know, I'm interested in goiters. It kind of sounds like hepatomegaly, which I hope our listeners recall from our previous GIT cycle, but for the thyroid.
Exactly. A goiter is just an enlarged thyroid gland. It doesn't tell you whether the gland is overactive, underactive, or functioning normally. It's purely a structural change. It tells you it's big and that there may be something wrong, but not exactly what's wrong.
Are there any other causes for this goiter that we should know about?
Well, one is iodine deficiency, especially in inland and mountain regions where the soil and water lack iodine. But in iodine-sufficient areas, we can see goiters due to enzyme defects in thyroid hormone production. Autoimmune conditions like Hashimoto's or even exposure to goitrogens like lithium or certain vegetables in large amounts.
Goitrogens would be substances that disrupt normal thyroid function by interfering with the iodine uptake or thyroid hormone synthesis. So, examples could be cabbage, broccoli, and even cauliflower. Honestly, no, that's a shame. Those are my favorite hot pot ingredients. So, walk us through the actual mechanism. How does iodine deficiency lead to this big, bulky thyroid?
So when iodine is low, the thyroid can't make enough T4. That leads to a drop in circulating thyroid hormones, which the pituitary senses. In response, it releases more TSH to try and push the thyroid to work harder. Over time, this chronic TSH stimulation causes the gland to hypertrophy and undergo hyperplasia, leading to diffuse enlargement.
So, the gland is basically bulking up to compensate for its own struggles, like trying to do more with less.
Exactly. Goiters can also be either diffuse or become nodular over time, as different regions of the gland respond unevenly.
Alright, so I know surgery is an option if the goiter is large, if it's compressing structures, or if it kind of looks suspicious. But honestly, surgery is kind of scary, so are there cases where we don't need surgery?
Definitely. If it's from iodine deficiency, dietary supplementation can fix it, and the goiter might shrink. If it's due to hyperthyroidism, we can use antithyroid drugs or radioactive iodine to reduce the overactive tissue. And in hypothyroid cases, levothyroxine can lower TSH and sometimes shrink the gland. If it's small and not causing problems, we often just monitor it.
And the radioactive iodine isn't used unless there's overactive tissue, right?
Correct. It's mainly for toxic nodules or Graves' disease, not simple or inactive goiters.
Alright, Noor. I don't know about you, but I am dying for a nice practice question to really solidify the information in the old noggin. So why don't you hit us with one?
All right. So a patient presents with tachycardia, weight loss, and proptosis. Labs show low TSH and elevated T4. What's the underlying mechanism of her eye findings?
So those would be caused by autoimmune stimulation of orbital fibroblasts by TSH-releasing antibodies, aka TRAP.
Correct. And this would lead to inflammation and glycosaminoglycan buildup. Let's take one more question. This time focusing on lab values, which are probably the most important thing to know for today's episode. In a patient with long-standing iodine deficiency and a diffuse goiter, which of the following lab patterns would you expect? A. Low TSH with low T4. B. High TSH and high T4. C. High TSH, low T4. D. Normal TSH, high T4.
Okay, so chronic iodine deficiency would mean low T4, and the pituitary is going to try and compensate. So I am thinking low T4 and high TSH.
Exactly. If you guys chose C as well, which is high TSH and low T4, then you're correct. That's your classic feedback response to insufficient hormone synthesis.
All right, thank you, Noor. Can we go to our next case, please?
Sure. Next case. A 54-year-old woman presents with fatigue, constipation, and feeling slowed down. She says she's always cold lately and has gained some weight, even though her appetite is down. On exam, her skin is dry, her speech is slow, and she's got delayed reflexes.
Okay, so this looks like a classic case of the aforementioned speedometer slowing down. Textbook hypothyroidism.
Yep. Hypothyroidism is when there's not enough thyroid hormone being produced. It can be due to a problem in the thyroid gland itself. That's primary hypothyroidism, or it can stem from higher up in the chain, like the pituitary or hypothalamus, which we can call secondary or tertiary hypothyroidism.
So it's kind of like adrenal insufficiency, right? We always have to ask, is the problem with the gland itself or the actual control center? All right, Noor, give me the who's, what's, and why's.
Well, it's a spectrum. In places like the US, where iodine levels are normal, the most common cause is Hashimoto's thyroiditis, an autoimmune attack on the thyroid. Don't worry, we'll get into that soon. Other causes include iodine deficiency, thyroid surgery, or radioactive iodine treatment, as well as congenital enzyme defects, and even certain medications like lithium, amiodarone, and interferon. In the secondary or tertiary cases, it's due to pituitary or hypothalamic failure. Basically, the command centers are not doing their job.
So there are lots of ways to mess with this system. We can either destroy the gland, block hormone production, or cut off the stimulation from above. As for its pathophysiology, we said that low thyroid hormone would slow everything down, causing less stimulation of metabolic pathways. This would cause decreased protein synthesis, slowed cardiac output, and impaired GI motility, as well as reduced thermogenesis. Though, do these patients have any specific physical appearances like we saw with exophthalmos and hyperthyroidism?
They do. A big hallmark is myxedema, which is the accumulation of glycosaminoglycans in the skin and soft tissues. The mucopolysaccharides pull in water and make tissues bulky, especially in the face, tongue, and even the vocal cords. That's what causes the puffiness and coarse facial features, as well as deeper voice.
And are there any classic findings to watch out for?
Let's run through some and link them to why they happen. 1. Fatigue and weight gain caused by a slower metabolism. 2. Cold intolerance due to reduced heat production. 3. Constipation due to sluggish GI motility. 4. Bradycardia, which is caused by the decreased adrenergic response. 5. Dry skin, brittle hair because of reduced protein synthesis. And lastly, the opposite of hyperreflexia, delayed deep tendon reflexes, especially the relaxation phase, due to slowed neuromuscular activity.
So far, this is quite literally the opposite of hyperthyroidism. And as we know, thyroid storm is a life-threatening complication of hyper. Do we have anything like that here?
That would be myxedema, coma, an emergency characterized by hypothermia, hypoventilation, and altered mental status.
That sounds pretty serious. I'd assume those affected with hypothyroidism would want to avoid such a consequence. Say, how do we treat hypothyroidism?
It's pretty straightforward. We don't have the hormone, so we replace the hormone. We use levothyroxine, which is a synthetic T4. The dose is titered to normalize TSH, and we check levels about 6 to 8 weeks after starting or adjusting the dose.
That sounds simple enough. All right, let's move on to our next case. So, Nour, the floor is yours.
Thank you. So we have an infant born in a remote village who presents with developmental delay, short stature, coarse facial features, and protruding tongue. The mother admits she didn't receive any prenatal care and there is no newborn screening program.
Short stature, coarse facial features, and the mom didn't get any prenatal care? This is starting to sound like cretinism, congenital hypothyroidism, right?
Exactly. Cretinism is hypothyroidism that occurs in infancy or early childhood. It can be due to maternal iodine deficiency or congenital thyroid dysgenesis.
Here's a fun fact for you, Nour. It's not that fun now that I think about it, but the word cretin actually means Christ-like because these people were thought to be so mentally disabled that they couldn't sin. That's pretty wild.
Yeah, definitely a dated term, but still used to describe this specific clinical picture.
A lot of medicine is based on old, outdated terminology. Anyways, you mentioned that the mother is from a remote village. Does this particular village have an endemic iodine deficiency?
Most likely, yeah. Mountain regions of China, Africa, or the Himalayas are all considered endemic areas. But congenital causes like thyroid agenesis or dyshormonogenesis, which is a genetic defect in thyroid hormone synthesis, can also lead to it.
And that's why we have newborn TSH screening in most countries now, to catch it before the damage is done. What about pathophysiology?
Thyroid hormones are critical for CNS and skeletal development, especially in the first few months of life. If a baby doesn't get enough T3/T4 during that time, you'd end up with severe mental retardation, short stature, coarse facial features, macroglossia, aka big tongue, umbilical hernia.
And it depends on when the deficiency happens, right?
Yes, if mom is hypothyroid early in pregnancy before the fetal thyroid develops, the brain damage is much worse. If it happens later, you might see growth delay without as much cognitive impact.
And what can we do for the kid in our case? Is there any hope?
Immediate levothyroxine replacement is crucial. If caught early, like within the first 2 weeks of life, the kid can develop normally. But if treatment is delayed, the neurodevelopmental deficits are usually permanent.
So we screen for it early, we want to catch it early, and then treat it early. Nour, do you smell that?
What exactly?
It smells like question time. Hit us with one.
All right. Let's test what we've learned. A patient with long-standing, untreated hypothyroidism presents with a puffy face, dry skin, bradycardia, and altered mental status. Labs show very high TSH and very low free T4. What is the most likely life-threatening complication? A. Edisonian crisis. B. Thyroid storm. C. Myxedema, coma. D. SIADH.
Altered mental status, hypothermia. This kind of sounds like myxedema coma to me.
Correct. If you guys chose C as well, myxedema, coma, then you chose the correct answer. Myxedema, coma is a rare but deadly complication of severe hypothyroidism, often triggered by infection or stress. All right, before we move on to our next topic, why don't we recap what we just discussed? Let's take it from the top.
Alright, so we started with hyperthyroidism, which is when the thyroid is in overdrive, making way too much T3 and T4. And here, our main player is Graves' disease, which is an autoimmune condition with thyroid stimulating antibodies that fire up the gland. In Graves, we would see exophthalmos, pretibial myxedema, and diffuse uptake on radioactive iodine scan. Thyroid storm is a life threatening complication here. As for symptoms, think of your metabolism on steroids: heat intolerance, tremor, palpitations, and hyperreflexia. Finally, we would treat it with methimazole, beta blockers, and radioactive iodine ablation, or surgery in some cases.
Okay, next we discussed goiters, which are just an enlarged thyroid. It's often caused by iodine deficiency in developing countries, and chronic TSH stimulation can also cause the gland to grow. If a goiter is big enough, it can cause compressive symptoms like dysphagia or hoarseness. For treatment, it depends on cause and severity. Most cases, we can just monitor it, but we can also do iodine replacement or surgery.
And next, we slowed things down and discussed hypothyroidism. Here, the gland isn't making enough T3 and T4. Symptoms would be the opposite of hyper, with fatigue, heat intolerance, constipation, dry skin, bradycardia, and a delayed reflex relaxation. For treatment, it's very simple. We just give levothyroxine. Don't forget the myxedema coma, though, which is a life-threatening emergency in very severe cases. Here we would see hypothermia, confusion, and bradycardia.
Finally, we discussed cretinism, or congenital hypothyroidism. This condition is a huge argument for newborn screening, as if this condition is left untreated, it can cause severe intellectual disability, short stature, macroglossia, and developmental delay. Some causes of it include maternal iodine deficiency, or congenital thyroid agenesis, or dyshormonogenesis. Finally, treatment is early levothyroxine. If we delay this damage can become permanent.
Alright, let's move on to thyroiditis. According to my notes, we have 4 types: Hashimoto's thyroiditis, subacute granulomatous thyroiditis, also known as Quervain, subacute lymphocytic thyroiditis, which can be silent or postpartum, and Riedel or fibrosing thyroiditis.
Your notes are spot on. Let's begin with another case. A 42-year-old woman comes in with fatigue, weight gain, and cold intolerance. She says her neck feels full and mildly tender, but not painful. On exam, her thyroid is symmetrically enlarged and firm. Her labs show high TSH, low T4, and she's positive for anti-TPO antibodies. So, without looking at your notes, what do you think?
I pinky promise I'm not cheating, and our listeners will have to trust me on that since they can't see me, but this sounds like Hashimoto's.
Why do you say that?
Because of the anti-TPO antibodies, the hyperthyroidism symptoms, and the non-painful goiter. Come on, am I right?
Well, you are correct. This is a classic case of Hashimoto's.
Oh, thank God.
So, Hashimoto thyroiditis is a chronic autoimmune thyroid disease. It's the most common cause of hypothyroidism in iodine-sufficient regions. So, places without the iodine deficiency, their immune system targets thyroid tissue, leading to gradual destruction. It's way more common in women, about 10-to-1 female-to-male ratio, and usually presents in middle age.
There's also a genetic component, right?
Definitely. There's strong association with HLA DR3 and DR5, and polymorphisms in immune regulatory genes like CTLA4, PTPN22, and IL2RA.
And what about its pathophysiology?
The core issue is loss of self-tolerance. The body produces antithyroid peroxidase (anti-TPO) and antithyroglobulin antibodies. These trigger CD8 cytotoxic T-cell mediated death, cytokine-driven inflammation, like interferon gamma from Th1 cells, and antibody-dependent cell-mediated cytotoxicity. Eventually, thyroid tissue gets replaced by mononuclear cells and fibrosis.
So it's like this slow, smoldering autoimmune attack that eventually burns out the gland, just like how the average med student feels burnt out. So what are some clues that can help us spot this?
Most notably, we have the painless, diffuse goiter plus gradual onset hypothyroid symptoms. Also, as you said, Positive anti-TPO and or anti-thyroglobulin antibodies are huge indicators of Hashimoto's. On histology, we would see Hürthle cell metaplasia, lymphoid aggregates with germinal centers.
And I remember that Hashimoto's can actually have a transient hyperthyroid phase too.
Yes, that's due to the destruction of follicles and hormone leakage, called hashitoxicosis.
Uh-huh. So we pop the balloon and the water will soak you. All right, so how do we treat it?
Treatment is lifelong levothyroxine. We also monitor TSH every few months initially, then yearly once stable.
And a little birdie told me to ask about the cancer risk. So is there any cancer risk here?
Hashimoto is associated with an increased risk of thyroid lymphoma, though it's rare.
All right, so we've covered most of the high yield points for Hashimoto's, so why don't we just jump to a new case?
All right, picture this, Yomna. A 45-year-old woman comes in with a sudden neck pain that radiates to her jaw and ears. She had a sore throat about a week ago, and now she's feeling anxious, sweaty, and losing weight. On the exam, her thyroid is tender and firm. What do you think?
Okay, so neck pain, hyperthyroid symptoms after a viral illness? This is giving me big Quervain energy.
Exactly, Yomna. Subacute granulomatous thyroiditis, also known as Quervain thyroiditis. This is a self-limited inflammatory condition of the thyroid that usually follows a viral upper respiratory tract infection. The key feature is pain. It's one of the only painful thyroid disorders.
And I'd assume that that makes it a very helpful distinguishing factor, right? Like if someone has a tender thyroid after an infection, then this would immediately go to the top of our differential list.
For sure, pain plus recent upper respiratory tract infection plus transient hyperthyroid symptoms equals a classic Quervain syndrome. It typically affects women in their 40s or 50s, and again, it's often preceded by a viral illness. Viruses like mumps, Coxsackie virus, and adenovirus are the usual villains here.
You know, I kind of love that it's like the immune system is being very overdramatic and going overboard. Kind of like, you gave me the flu last week, I'm gonna wreck your thyroid.
Pretty much. That immune response ends up by damaging thyroid follicles and releasing all the performed hormone into the bloodstream.
Okay, so tell me more about the pathophysiology. From a more formal aspect, that is. I doubt I can write what I said in an SAQ.
So what happens is the infection causes inflammation. That disrupts the follicles, leading to leakage of T3 and T4. That's why these patients often have symptoms of transient hyperthyroidism. On histology, you'll see granulomas, multinucleated giant cells, and destroyed follicles surrounded by inflammatory cells.
So this isn't the thyroid making too much hormone. It's more like it's dumping out whatever it had stored.
Exactly. And because it's not actively producing more hormones, the RAI, quick reminder, radioactive iodine, uptake is low, which helps differentiate it from something like Graves'. Some more key things to look out for are a painful, tender thyroid, recent upper respiratory tract infection, signs of thyrotoxicosis, but with low RAI uptake, and labs show low TSH, high T4, then possibly followed by a hypothyroid phase.
And do patients usually recover completely?
Yes, they do. Most go back to normal within 6 to 8 weeks. It's like a roller coaster. Hypothyroid phase, sometimes dip into hypothyroid, then euthyroid recovery.
And how would we treat these cases?
Treatment is usually supportive. Beta blockers if there are symptomatic from the hyperthyroid phase, and if it's severe, some patients might benefit from a short course of steroids.
And there isn't a role for antithyroid meds here, right?
Right, because the gland isn't overproducing hormone. That's why checking the RAI uptake is so important.
Okay, so that just about covers the Quervain. So we are now halfway through the thyroiditis. Why don't we have a quick question to keep us in check?
Gladly. So, which of the following is most strongly associated with Hashimoto thyroiditis? A. Hürthle cell and granulomas. B. Hürthle cells and lymphoid aggregates. C. Follicular hyperplasia and semomas bodies. D. Colloid goiter with no antibodies.
Hürthle cells, lymphoid aggregates with germinal centers. So that would be B.
Exactly. Those are very, very typical histological findings seen in Hashimoto's.
Hashimoto's, Hertel, HNH. All right, shall we move on to our next case?
We shall. Next up is a 30-year-old woman, 3 months postpartum, comes in with mild anxiety, weight loss, and palpitations. Her thyroid is not tender, but slightly enlarged. Labs show low TSH, elevated T4, and positive anti-TPO.
You emphasize the postpartum part. Is this perhaps postpartum thyroiditis?
Exactly. Subacute lymphocytic thyroiditis, also called silent or painless thyroiditis. It is an autoimmune thyroid inflammation. It can happen postpartum or spontaneously. It's most common in middle-aged women, often in the postpartum period, up to 5% of pregnancies.
So basically, it's like Hashimoto's sneaky little cousin copycat that shows up after you give birth?
Exactly. And it can come with mild hyperthyroidism, a painless goiter, or both.
So why does this happen anyways? What's the story behind its pathophysiology?
There is lymphocytic infiltration of the thyroid, leading to destruction of follicles and hormone leakage. But unlike Hashimoto, you don't get much fibrosis or Hertel cell change.
Why don't you tell me a little more on the treatment of these cases?
Most patients actually recover without treatment. Beta blockers can be used if hyperthyroid symptoms are bothersome. Rarely, they may need levothyroxine if hypothyroidism persists. Finally, let's go over the last case before we review some questions. We've covered a lot of information so far. Yomna, I hope you're still with me.
Yeah, sure, definitely. I still am. You know, I'd ask for a coffee break, but I think our recording supervisors would kill me. Anyways, case time?
I promise you a coffee later. So, we have a 50-year-old woman presented with a rock-hard neck mass. It's painless, but immobile. She's experiencing some hoarseness and trouble breathing. Imaging shows tracheal compression.
This sounds like a thyroid cancer, but we're discussing thyroiditis still, so this must be Riedel thyroiditis. It's the one that mimics thyroid cancer.
Correct. Riedel thyroiditis is a rare form of chronic inflammation that causes extensive fibrosis of the thyroid and surrounding tissues. It's very rare and of unknown cause, but it might be part of the IgG4-related disease spectrum.
Oof, that sounds quite scary, honestly. Tell me more about its pathophysiology and some clues to watch out for.
There is dense fibrosis that extends beyond the thyroid capsule into surrounding neck structures, leading to compression of the trachea, esophagus, and nerves.
We can't just assume it's Riedel, so how would we treat it?
Treatment can include surgery to relieve compression and steroids if there is active inflammation. Some patients need thyroid hormone replacement if the gland is non-functional.
Oh god, that was a lot. Alright, now how about some practice questions to really solidify all of this?
Gladly. All right, so we have a woman, 3 months postpartum, presents with weight loss, tremor, and anxiety. Labs show low TSH and high T4. Thyroid is non-tender. What is the most likely diagnosis? A. Graves' disease. B. Postpartum thyroiditis. C. Toxic adenoma. D. Hashimoto thyroiditis.
I'm gonna go with B. Postpartum thyroiditis, especially with that painless gland and the timing.
You are correct. All right, before we move on to the final part of our episode, why don't we recap thyroiditis? Take the mic, Yomna.
Okay, so first up, Hashimoto's thyroiditis. It is a chronic autoimmune destruction of the thyroid, which leads to gradual hypothyroidism. Here we can see positive anti-TPO antibodies and histology, which shows the classic Hertel cells and lymphoid aggregates. Hashimoto's often presents with a goiter, and it has an early transient hyperthyroid phase.
As for clinical clues, we would have a rock-hard fixed painless thyroid, as well as compressive symptoms, hoarseness, dysphagia, and stridor. Also, hypothyroidism in some cases can occur. And finally, it mimics anaplastic carcinoma clinically and on imaging.
So we really do have to keep thyroid cancer on the differential list until a biopsy confirms. Hashimoto's often presents with a goiter, and it usually has an early transient hyperthyroid phase called hashitoxicosis. And also, Hashimoto's is associated with thyroid lymphoma. Finally, treatment would just be lifelong levothyroxine.
Okay, so next we have subacute granulomatous thyroiditis, or Quervain. It often follows a viral upper respiratory tract infection. Key features: include a painful thyroid and transient hyperthyroid symptoms due to hormone leakage. Histology shows granulomas, multinucleated giant cells, and disrupted follicles. We treat it with NSAIDs and beta blockers, as it's self-limiting usually. Finally, its RAI uptake is low.
Third on our list is subacute lymphocytic thyroiditis, also called silent or postpartum thyroiditis. It's an autoimmune condition, usually seen postpartum from the name. Key features include a painless thyroid and transient hyperthyroidism. Labs are similar to Hashimoto's, with anti-TPO being positive. And histology would show us lymphocytic infiltration without fibrosis or Hürthle cells. Finally, treatment would be supportive.
Last, but certainly not least, is Riedel thyroiditis. It's rare and possibly a part of a IgG4-related disease. Key features include a rock-hard fixed and painless gland with compressive symptoms. Histology shows dense fibrosis. It's treated with steroids, surgery for decompression, and levothyroxine if hypothyroid. Finally, it can mimic anaplastic thyroid carcinoma, so we have to biopsy to rule out cancer.
Okay, so we finally made it to the last part of today's episode, thyroid tumors. And listen, I know when people hear tumor, it sets off these huge alarm bells, but let's clarify something from the get-go. Most thyroid nodules are not actually cancer, right?
Exactly. Nodules are super common, especially in women. In fact, up to 50% of people might have a thyroid nodule on imaging, but only about 5 to 10% of those turn out to be malignant.
All right, so most are benign, but because this small percentage can be cancerous, it's also important to evaluate them properly so we don't miss anything. All right, so let's begin with the benign side of things. Adenomas. Nour, hit us with a case.
Imagine, Yomna, a 38-year-old woman comes in after noticing a small lump on her neck while applying lotion. She is otherwise totally asymptomatic. Her labs are normal, ultrasound shows a solitary, well-defined nodule, and a biopsy confirms it's a follicular adenoma.
You know, Noor, I feel like this is such a common story. Someone would find an accidental lump, in this case on the neck, and it would send somebody into a panic.
It really is. A thyroid adenoma is a benign neoplasm of follicular epithelium. Most are non-functional, meaning they do not produce excess hormone, and are cold nodules on a thyroid scan.
Cold nodules, you said?
Yes, cold nodules are thyroid nodules that do not take up radioactive iodine, suggesting they are non-functioning and carry a higher risk of malignancy. Hot nodules take up radioactive iodine more than the surrounding tissue, indicating they are hyper-functioning and are rarely cancerous.
Okay, so thyroid adenomas are non-functional. Could they possibly be hot nodules sometimes? Like if they're maybe autonomously secreting T3 and T4?
They could be. Those are called toxic adenomas, and they can cause symptoms of hyperthyroidism, but most adenomas don't.
So thyroid adenomas are much more common in women, and they often show up between the ages of 30 to 50. There's no clear cause, but some arise after long-standing TSH stimulation or radiation exposure.
That is correct. And adenomas are encapsulated tumors arising from follicular epithelium. The big deal is making sure they are not carcinomas, because some features can overlap, especially in follicular neoplasms.
And the only way to be sure that it's not cancer is to examine the capsule, right?
Yes, you have to surgically remove it and look for capsular or vascular invasion, because you can't reliably tell from just fine needle aspiration cytology.
And are there any particular clinical clues that can guide us?
There sure are. These adenomas are usually a solitary cold nodule in a euthyroid patient. If it's functional or hot nodule, it may cause hyperthyroid symptoms. Finally, on biopsy, no invasion is seen.
And how would we treat these cases? Seeing as it's so benign, can we just monitor it?
Yes, you can. If the nodule is small and clearly benign, it can be monitored. But if it's large, growing, or suspicious, then surgical excision is done to rule out malignancy.
And the prognosis is excellent if it's a true adenoma.
Absolutely. Now, let's take another case. Next up, we have a 29-year-old woman finds a painless nodule on her neck during a routine self-exam. She has a history of childhood radiation to her neck for acne. Ultrasound shows microcalcifications and FNA reveals cells with characteristic orphan Annie I nuclei.
So, radiation exposure, microcalcifications, and those creatively sounding nuclei. Is this papillary carcinoma?
Yup, this is papillary thyroid carcinoma, the most common thyroid cancer. It accounts for around 80% of all cases.
And even though it's called carcinoma, this one actually has a good prognosis, right?
Exactly. It's well differentiated, grows slowly, and rarely kills. Most patients live long, healthy lives after treatment. It's most common in young to middle aged women, especially those with a history of radiation exposure to the head or neck.
And genetically, we're usually talking about mutations in BRAF and RET/PTC, right?
Right. BRAF mutations are linked to a more aggressive course, but most papillary cancers still behave well clinically.
All right, and how about you tell me a little on the pathophysiology of it?
So the tumor originates from follicular cells, but unlike follicular carcinoma, it tends to spread via lymphatics to cervical lymph nodes.
That sounds scary, but it doesn't actually worsen the prognosis much, right?
Exactly. Lymph node involvement is common but does not significantly affect survival. It has some classic features on histology, including the orphan Annie I nuclei, which are pale, empty appearing nuclei due to chromatin clearing, samoma bodies, layered calcifications, nuclear grooves, and inclusions, and papillary architecture, hence the name.
And a little fun fact for our listeners, the term orphan Annie I nuclei refer to the comic character with those big blank eyes. It's pretty creepy, but memorable. So how do we treat this node?
This is usually managed with surgery, either lobectomy or total thyroidectomy, depending on tumor size and risk.
And sometimes we add radioactive iodine ablation, right?
Yep, especially for higher risk cases. And we suppress TSH afterward with levothyroxine, since TSH can stimulate tumor growth. Okay, Yomna, question time. Why don't you give us one for a change?
Why must you make me work, Nour? Anyways, which histological finding is most characteristic of papillary thyroid carcinoma?
Orphan Annie nuclei? Thank you. All right, on to our next case. A 65-year-old woman from an iodine deficient region presents with a solitary thyroid nodule. FNA suggests a follicular neoplasm. After thyroidectomy, pathology shows capsular and vascular invasion.
All right, so this isn't just a benign adenoma. It's follicular carcinoma, confirmed by the invasion.
That's correct. This is the second most common thyroid carcinoma. It also comes from follicular cells, like papillary, but behaves differently.
Right, and this one spreads through blood rather than lymph.
Right. Hematogenous spread to bone, lungs, and liver is classic. It's also more common in middle-aged to older women, especially in regions with low iodine intake. Mutations include RAS and PAX8/PPAR gamma.
So what separates follicular carcinoma from an adenoma is invasion, either into the capsule or the blood vessels. And like we said, fine needle aspiration cannot tell the difference. And that's what makes it so tricky.
That's why we need to excise the nodule to see if it's invading. There are some other clinical clues though, like a solitary, painless thyroid nodule, often cold on scan. The nodule also spreads to distant organs, not lymph nodes.
What about the treatment?
We typically do a total thyroidectomy, followed by RAI ablation. Long-term prognosis is good, but worse if there is extensive vascular invasion.
All right, guys, and we cannot emphasize this enough, but early detection is very important. All right, shall we move on to our next case?
We shall. A 43-year-old man presents with a thyroid mass and watery diarrhea. His labs show elevated calcitonin, and biopsy reveals amyloid in the stroma. He has a strong family history of MEN2A.
All right, so that combination of diarrhea and the calcitonin just screams medullary carcinoma to me.
You're correct. This is medullary carcinoma, a cancer that arises from parafollicular C cells, not follicular cells.
And these C cells secrete calcitonin, which doesn't do much physiologically, but it is a great tumor marker.
Medullary cancer can be sporadic or familial. Familial forms are linked to MEN2A and MEN2B and involve RET proto-oncogene mutations.
And before surgery, we must rule out pheochromocytoma in these patients, or the stress of the surgery could trigger a crisis.
Exactly. Check plasma metanephrines pre-op. The tumor also secretes calcitonin, which can cause flushing, diarrhea, and sometimes ACTH, VIP, and serotonin levels may also increase.
And how does it look histologically, Noor?
We would see polygonal or spindle cells and amyloid deposits in stroma from altered calcitonin. We also have some other clinical clues, like high calcitonin and CEA levels.
Interesting. And these are associated with MEN2 syndromes, which are autosomal dominant disorders characterized by RET proto-oncogene mutations. How do we treat this?
Treatment includes a total thyroidectomy and monitoring calcitonin post-op for recurrence.
Would we not use RAI in this case?
Nope. RAI does not work because C cells do not take it up.
Alright, Noor, why don't we go with one last case before we wrap up for today and go enjoy our weekends finally?
Stay strong, Yom. Just one more case left. So, we have a 72-year-old woman who presents with a rapidly growing rock-hard neck mass. She's hoarse, short of breath, and imaging shows tracheal compression. Biopsy shows giant cells and pleomorphic spindle cells.
Ugh, this one's tough. Sounds like anaplastic carcinoma, the worst of the lot.
Yep. Anaplastic carcinoma is a highly aggressive, undifferentiated cancer. Thankfully, it's very rare, as it's often fatal within months. It mostly affects the elderly, evolving from prior papillary or follicular cancers. And there are some mutations associated with it, like TP53, BRAF, PIK3CA.
What about its pathophysiology?
Well, the tumor grows rapidly, invades local tissues, and does not resemble normal thyroid tissue at all. Also, it's important to note that it's negative for thyroglobulin and TTF1.
And that makes it almost impossible to treat, right?
Exactly. Most cases are unresectable, and radioactive iodine is useless.
So would we even treat it, or do we just give the patient palliative care?
Unfortunately, the prognosis is very poor. So yes, treatment is usually palliative. Radiation and chemo may slow progression briefly, but survival is typically less than 6 months.
You know, this is such a stark contrast from papillary or even follicular cancer. All right, let's wrap up with a question or two before we give our listeners a nice little recap of the thyroid tumors. Noor, please don't make me do the asking part.
Don't worry, you. I'll do the asking part. All right. So what pathologic feature confirms a diagnosis of follicular carcinoma? Let me give you the choices. A. Orphan Annie eye nuclei. B. Samoma bodies. C. Vascular and capsular invasion. D. Amyloid deposition.
I'd say C. Vascular and capsular invasion. That's what makes it a carcinoma anyways.
Correct, you. Now, second question, and our final one for today. A thyroid tumor shows amyloid on biopsy and produces calcitonin. What genetic mutation is most likely involved? A. BRAF. B. RET. C. PAX8. D. TSH receptor.
This would definitely be B.
That is correct. RET is associated with medullary carcinoma, especially in men too.
Phew, that was a ton of thyroid knowledge. But if you're anything like me, you're gonna want a quick run through of it all to lock it in before we call it a wrap.
First, we discussed benign tumors, the adenomas. Most are non-functional or cold. We can't rule out cancer with FNA, so we need to surgically excision to check for capsular invasion.
And then we discussed the big four thyroid cancers, each differing in how they behave, kind of like the Brady Bunch. Papillary carcinoma is the most common, linked to radiation exposure. It has lymphatic spread but an excellent prognosis. Some keywords to keep in mind include the orphan Annie nuclei, Samoma bodies, and nuclear grooves.
Next, we discussed follicular carcinoma, which is the second most common one. This is seen more in iodine-deficient areas. This spreads hematogenously to the bone, lungs, and the liver, and we confirm it by spotting capsular or vascular invasion.
Then we moved on to medullary carcinoma. This one arises from C cells and secretes calcitonin, which causes diarrhea and flushing. Then we discussed medullary carcinoma. This one arises from C cells and secretes calcitonin, which causes diarrhea and flushing. It's also associated with MEN2A and MEN2B, caused by RET mutations. And finally, we can see amyloids on biopsy.
Last, we have anaplastic carcinoma. This is the most aggressive one, and it happens in elderly patients. It's characterized by a rapidly enlarging mass and compressive symptoms. It has poor prognosis, it's unresponsive to treatment, and histology would show us pleomorphic spindle cells.
Oh my goodness, Noor. I think we covered more thyroid content than the gland can produce in a lifetime. We hope this episode helps aid you in your exam prep or to help you impress others on rounds.
Thanks for tuning into PodBites. Don't forget to follow us for more episodes. And until next time, stay curious and take care of your necks, folks.
Especially if they start growing out of nowhere. Apologies, but I am dying for a nice little practice question to really solidify the information in the old blah 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 blah.
انت ليش متفلسة؟ شو هي؟
يا بنتي, I was in كنت بcoffee shop. طيب كنت مروقة. I had my latte, I had my croissant. طيب I was like, the old noggin.
From my eyes, Yomna. All right. So patient presents with tachycardia.
Sad, why are you laughing?
لازم أقول من عيوني, مو from my eyes.
Say من عيوني. I didn't have the Arabic keyboard. I was on my other keyboard. Say من عيوني.
من عيوني يمنى. All right.
Okay, you can don't say all right. Just من عيوني يمنى. Pause. A patient presents. Okay, remove it. I'll just remove it.